to present his experience on managing viral hemorrhagic fevers from the laboratory perspective, in particular on Ebola, Marburg disease, Rift Valley fever, Mpox, and other emerging infectious diseases. Dr. Daniel Mukadi, you have the floor.
Thank you very much, Chairperson, and I hope you are seeing my slides. It was asked to me to present on. Oh, sorry, I've lost the cursor. Yeah. Case studies and lesson learned, and to share the experience from outbreaks, VHF outbreaks, our success and our challenges. I've tried to summarize most of my key points so that I don't go far from the topic. This is the outline of my presentation. First, I'll show the background and then talk about the experience from Ebola outbreaks in DRC, which are the most important, and the challenges, and finally, success and lesson learned. The DRC, as you can see on this map, is the second biggest country of Africa, with a land area of more than 2 million km square. And since its recent history, the country has faced 16 Ebola outbreaks, among which 15 were of Ebola Zaire. As you can see on this diagram down here, we have had 9 outbreaks in a lapse of last 9 years. That makes things very, very critical from DRC side. And most outbreaks involved Ebola Zaire, but with different variants. So we have a variant, the variant Mayinga in the northern parts of the DRC and also in the eastern parts. We had the variant from Kikwit here in the center of Africa and also in the northern parts. And we have another variant in the center of Africa. From all these Ebola outbreaks, what was the DXP experience? I would like to summarize it in 3 key points. The first is the therapeutics, the second, therapeutic and vaccines, and the third would be the diagnosis. And from that, we'll see the lessons we learned. And regarding our experience from Ebola outbreaks, I will be just taking the recent ones. For example, during the EVD 9th in 2018 and EVD 10th from 2018 to 20, we have switched from MURI protocols to randomized control trials, especially with therapeutics. And this is the timeline of events. On May 2018, an outbreak of Ebola was declared in Bikoro. Bikoro is Equatorial province in the northern part of the country in the equatorial forest. And on May 17, 2018, we had 4 confirmed cases. That triggered the WHO to call for a meeting with independent experts, then to decide on how to evaluate the introduction of investigational therapeutics. And on May 18, WHO raises a concern about Ebola, and 3 days later, WHO and Ministry of Health in DRC started the vaccinations using the Ervebo, the RVSV vaccine just mentioned in previous presentation. And on May 29, the DRC Ethics Committee approved the use of remdesivir and favipiravir. And on June, they approved the use of ZMapp, Regeneron, and MAB114 for that outbreak. But the thing was that that outbreak was very short. The approval was obtained on June 1st, and on June 6th, we confirmed our last case. And on July 24, the outbreak ended because there were no more confirmed cases. However, 8 days later, another outbreak of Ebola occurred, but in the other region in the eastern DRC, at the border of almost Uganda. And on August 1st, that outbreak was declared in Mangina region in North Kivu province. It was confirmed 6 days later that it was a strain, Ebola Zaire strain, and that strain could support the use of RVSV or the Ervebo vaccine, the ZMAP and MAB 114 due thanks to in silico analysis done by INRB team in DRC and with collaborators. And on August 7, the ethics committee approved the EAP for Avrebo and Mabon-on-4. And the same day, clinicians arrived in Beni. Beni was one of the cities which was affected by Ebola at the beginning of the outbreak. And August 8, WHO and the Ministry of Health started the RVSV ring vaccination, the vaccination around confirmed cases. So that involves contacts and contacts of contacts. And then on August 10th, the INRB team will treat the two first patients with investigation products in ERP use in Mangina. And from August 11 to 13, 8 more patients were treated in Mangina. From that, MSF extended its capacity in the field with an Ebola treatment unit of 74 beds in Mangina. And 2 days later, Alima did the same with Ebola treatment unit in Beni, where those therapeutics will be later administered. And then on August 20, the DRC received the approval from IRB to use also ZMAP, remdesivir, and Regeneron as Ebola-specific therapeutics. From this experience, we were able to introduce clinical trial with therapeutics from mirror protocol, which was used in a compassionate manner now to be a randomized control trial, which later will come to conclusive statements regarding the use of Regeneron and MAB114 as a principal therapeutics for Ebola. And then here I'm sharing the picture of Professor Muyembe and the team of clinicians here, Professor Sabwe and Dr. Olivier Chani, coming from the NIH. They work on the MAB 114 and they did administer that in those patients. And a few days later, we are showing here the picture of the two patients, the two first cures of Ebola after receiving MAB 114 for Ebola in 2018 in Mangina. That was the story of therapeutics, and then the clinical trials moved forward. We had another key point was the diagnostic, how to organize the diagnostic in the field. And we have been able, in this paper from published in Emerging Infectious Disease, our team tried to summarize key components of deploying laboratories, especially for VHF. What are, for example, factors which we could influence the deployment of field laboratories? For example, increased number of confirmed cases, lack of pre-existing laboratory in the area, possibility that the outbreak crosses internal or external borders or reaches big cities with high population mobility, the possibility that the outbreak reach areas with high density of population, etc. We have also set up different key points to be addressed before the deployment, such as logistical challenges, availability of resources, workforce, and logistics, etc. During this outbreak, our success in the diagnostic was based on the capability and the flexibility that we had at that time to deploy 13 field laboratories within 3 affected provinces and all managed by one entity. It was the National Institute for Biomedical Research, INRB. As you can see, the timeline from August 2nd up to October 28th of 2019, we deployed in total 13 laboratories, field laboratories in 3 provinces to ensure that we have the diagnosis. And this model was replicated during the 2020 outbreak in Ecuador, where we were able again to deploy 5 different laboratories in the field to ensure the diagnosis. And how that could be possible if we couldn't have a coordinated actions. And we drew and we presented this organogram with the key components of the management. We had at the right side the field laboratories in blue representing North Kivu provinces, in dark green Ituri provinces, and in green South Kivu provinces. All these laboratories were led by their one leader, and they were all depending on the coordination with one coordinator assisted by 3 deputies in charge of operation, logistic, administration, and data management. And the middle represented, in fact, the intermediate level, and at the left, it was the central level where the general director of INRB and the head of department were directly conducting the response through this organization. And from this, we have been also able to draw the layout of field laboratories. These are the layouts that we propose, and you will find them in the paper that I showed before, where we had basic setup in certain areas and more advanced setup. We can see that the layout is a bit different depending on activities we had. For example, in advanced setup, we could have blood chemistry, blood hematology, and others. We could also have genomic sequencing capacity, whereas in the basic setup, we could have only diagnosis and maybe biochemistry, mostly for patients. And here I'm sharing just one picture of an advanced setup in the field in Beni, and two other pictures or 2 sets of pictures for one field laboratory in Biakato in Ituri province, and the other one in Mangina where the outbreak started in 2018. And then my other point now is what were the challenges that we met? Most challenges here we met were the procurement of reagents. As you know, we use equipment, instruments that mostly were purchased in Europe, in the US, maybe most of them. So the circuit of purchase, logistics, and funding was quite easier during outbreak because the response was funded and supported. But later, once it come to only Ministry of DRC to take care of all this, and it was a little bit difficult because of the circuit and also lack of funding. The other issue was the shipment. We had 13 laboratories in the field. We were generating almost 500 samples per day, and those samples need to be secured, shipped in adequate areas, and we should maintain the cold chain. And mostly with chartered flights, thanks to the WHO support and other partners. We should also ship reagents and materials and fridge equipment, etc. And those reagents would require sometimes the cold chain, especially for genomic sequencing. The other challenge was the maintenance of this equipment and also the availability of spare parts. As you know, if you use for example, the Gene Expert, the Piccolo, the Sysmex for diagnosis and chemistry and hematology, after a certain number of testing would require the maintenance of those equipment. So we needed to have people trained and also available spare parts to be sure that we can replace while we are conducting the outbreak. And thereafter, the issue was the concern raised regarding the sustainability of all actions were undertaken because they needed motivation. We should be paying workforce, staffing, logistics, power to run the refrigerators, freezers, and also those instruments. And so that required funding to have those people moving around, going to the field, etc. And finally, in other circumstances, we were obliged to decommission our laboratories because the workload was reduced and the support was also reduced. It was quite hard to have all the laboratories working at the same time. I want to end now my presentation with what were our successes. I could not mention all of them in this presentation because of the time. I've just chosen some, but I will be happy to share the rest maybe in the QA session. Regarding the success and lesson learned, I wanted to end up with 6 lessons. The first lesson is we changed the way of managing outbreaks. If initial or previous outbreaks were mostly relying on the diagnosis of Ebola, from 2018, we were able to have those point of care for blood chemistry, for hematology, for molecular assays, so that in addition to the diagnosis with point of care, where we did reduce the turnaround time for the result delivery, we were able to provide blood chemistry, hematology, that improved a lot the standard of care and the support, the care to the patient, in addition to the specific therapeutic that we had. Later on, for the other following outbreaks, we did use the same principle, not only the diagnostic tools, but also the other supportive equipment to be sure that the patient is correctly taken correctly cared. The second lesson that we learned and we quickly implemented in DRC is the decentralization. We had 15 laboratories in 3 provinces, and we were supporting the diagnostics. Later on, when the SARS-CoV-2 pandemic started, we were able to do the same in the country. But we will say, in fact, every country in the world did the same. I do agree. But now we have an ongoing mpox outbreak of clade 1A and 1B in the eastern DRC. And so far, DRC in all Africa is the first country to have a very large testing field laboratories, as you can see them here, represented by the green square and also the red one. From the west in Kinshasa, here, the capital city, in the center, in the north, and also in the eastern DRC. And you can also see how many laboratories are working, are functional just at the borders with Burundi, Rwanda, and Uganda to be sure that we can contain, we can support the diagnosis of this region. And the most important thing, as lesson, we learned tiered management of the laboratory at central, intermediate, and peripheral levels. In addition to that, we were able to create 2 big biorepository, one in Kinshasa with a capacity of more than 1 million of samples. And as of now, we have more than 7,000 Ebola, mpox, and SARS-CoV samples which are stored. And the other biobank is in Eastern DRC, actually in Goma, with more than 300 samples stored, including Ebola, SARS-CoV, mpox, plague, and others. This is a legacy of what we have learned from this outbreak. My third lesson will be the new infrastructure, building from our misfortune to convert them to happy events. I'm showing the picture of INRB, the National Laboratory of Public Health of the DRC in Kinshasa before, and later with the opportunity of outbreaks, we have been able to build, thanks to the Japanese cooperation, a big BCL3 of and new facilities in Kinshasa. But we did replicate the same at a small extent in the Eastern DRC, in Goma, where thanks to the Fondation Mérieux, we were able to deploy also BCL3 laboratories now working as a big centers of diagnostic, research, and training. And from this, we were able once more again to decentralize the diagnosis and also be able to provide result for surveillance of almost Eastern DRC. The fourth lesson is the capability or the capacity that we had through these outbreaks to conduct clinical research and other researches. From this, as you can see on different papers, we were able to conduct clinical trials, ecological study, evaluation of diagnostic tools, genomic sequencing, serology, thanks to the opportunity that we had from the outbreak. And now we have been able to integrate that aspect, the concept of outbreak research investigation during our epidemics. The fifth lesson is the benefit of having all those diagnostic tools available in our areas so that we can conduct the biological surveillance for different pathogens, not only VHF. VHF at the beginning, but later we expanded our capacity to other pathogens also could able to create VHF such as Rift Valley, arboviruses, RVF, Marburg, and other. This is something we're able to do. And also the genomic sequencing capacity that we're able to decentralize so that now in almost our outbreaks, the genomic sequencing laboratory is deployed at the same time as the diagnostic laboratory. So we could in real time have the sequence, the mutation, and we can be monitoring different aspects of the virus. We were also able to organize the follow-up of people who are receiving therapeutics or vaccines to see what was the biological parameters which could be disturbed because of those administration, especially in the therapeutics. And we're able from 2018 to now to conduct post-outbreak activities, especially in Ebola survivors. As you know, the DRC as the second biggest cohort of Ebola survivors after Guinea. And as of now, for the ongoing outbreak in Bulape, we are able to organize the survival program with clinical, biological, and also psychological support for a year or even 2 years. My last slide will be the lesson 6. We were able to empower the workforce, local workforce, so that they have capability in clinical trials, data management, ethics, biosecurity and biosafety, the ability to run, to operate in high containment infrastructures such as a BCL3, BCL2, and also Ebola treatment unit, also the capability to manipulate different instruments and troubleshooting, sequencing capacity, the surveillance, and even the incident management system. The DRC has strongly changed the way of leading or responding, organizing response to different emergency, now integrating the aspects of incident management with all the consequences. And from that, my last point is that in DRC now, in this lesson, we have been able to set up a clinical research center in collaboration with different partners where we can be reviewing clinical research in the field in DRC. And we are so happy that many studies have gone through this clinical research center, which represent a success. This is all for my presentation. I will be happy to take your questions. Thank you, Chairman.
Thank you, Dr. Daniel Mukadi. I think your presentation was very